here we go. Participation is necessary. First and foremost, just a little reminder. If you are ever on your medicine team and you're calling a cardiology consult or just calling a consult in general, there's sort of 3 very important things before you get on the phone to ask for help. Because oftentimes with these patients, you get concerned and you want help. You got to know the question that you're asking. So if you're going to call the cardiology team, you're going to call me to ask for help in the middle of the night. Know what you're asking for. So don't just call and say, I have a 45-year-old patient, history of osteoarthritis, constipation, and you go on and on. I've stopped listening to you as soon as you said osteoarthritis. So know what question you're going to ask. Know about the patient. So if I ask you what's the creatinine or what happened to the patient yesterday, you know that too. And then know the acuity of what you're asking for and of what you need. And especially in cardiology, that's very important because there might be something that we can take care of tomorrow, or you might literally need right now, this patient is going down and I need your help. So if you keep those 3 things in mind, it will help me to help you. All right, so we're going to talk about acute coronary syndrome, but first we've got to talk about the basics of coronary perfusion, okay? When you're thinking about acute coronary syndromes, I want you to always be thinking about the coronary artery, the blood vessel. And you're always trying to think about what's happening inside that blood vessel. So this is really about a supply and demand phenomena. So I want you to tell me, what are some of the things that might decrease supply in the myocardial vessels? What's that? Say it louder. Okay, good. Hypotension. Oh, almost. Good. Okay, hypotension is one. What else? Good. So you have narrowing of the lumen of the artery. What else? So that's stable atherosclerosis. What might happen acutely? Go ahead. Oh, good. I like it. Vasospasm. That narrowed the diameter for your friend. Told you I'm a bad thrower. Okay. What else? 2 other main things I want you to hit. Okay, so if you actually have decreased, that's stretching it, but I'll take it, decreased oxygen tension in the artery. Okay, what else? Not directly. That can change the perfusion pressure. I'll give you candy for venturing, but not directly. I'm on fire today. Make sure you sit on this side of the divide. Come on down, guys. Okay, and emboli. So you're getting at something that acutely narrows the lumen, like acute coronary syndrome. Good job. Wow, you're an even worse catcher than I am thrower. I was really nervous about that. And then another final one I'm going to put on the list is about aortic stenosis. So if you have aortic stenosis and you're actually ejecting less blood out from the heart, then you're going to have less blood going down the coronaries, right? Because the coronaries take off just after the aortic valve. Okay, good. And then we didn't talk about decreased preload, but hypotension can sometimes also have that effect, right? That you have decreased preload actually getting through the heart. Okay, so that's what decreases the supply. But notice that we're talking about acute coronary syndrome, but ACS and plaque rupture is only one of the possible things that could decrease supply to the coronaries. And your job, whenever you have a patient with chest pain, positive biomarkers, is to try and figure out which one of these is going on. Now, on the converse side, we could have an increase in demand. So what might increase in the demand for blood flow down the coronaries and therefore give you inadequate blood supply? Good, tachycardia. You already got candy. I'm not giving you another one. What else? Okay, yep, so sepsis. I'll give you that. Increased metabolic rate. Nope, behind you. What else? And there are increases in demand specifically in the heart, coronary arteries we're talking about.
Exercise?
Yeah, so tachycardia goes along with that, right? So anything that's going to increase that wall stress, so tachycardia. What else would happen during exercise? Another hemodynamic parameter. What happens to your blood pressure? Goes up, right? So hypertension is also going to cause increased demand. That's going to cause increased demand by increasing the afterload on the heart. So the heart has to pump against more, and therefore the muscle needs more blood supply. Anything else you guys can think of that increases demand? Yeah, so heart failure is the other one, and if you rotate with me, which hopefully all of you will, then you'll see that I talk about this all the time. Heart failure can cause chest pain and positive biomarkers. And the way that it does it, I'll teach you when you're around with me, but basically the long story short is when you increase the pressure inside the ventricle, that's called left ventricular end diastolic pressure. Talk about that a lot. When you increase the pressure because of the increased volume in the heart, you actually are going to decrease the perfusion pressure down the coronaries. I'll teach you more about that in another lecture, but just keep in mind that heart failure, being in heart failure, volume overloaded, can also increase the demand through the coronary arteries. Okay, so again, you're thinking, whenever I approach a patient with chest pain, and with positive biomarkers or evidence of ischemia on EKG, I'm thinking through this whole list of supply and demand phenomena because I'm trying to figure out what's the mechanism by which I did not perfuse the heart. So this is a lecture about acute coronary syndrome, so we have to talk about what is a myocardial infarction. And you might think that's a very easy thing to define, but it turns out it's not. So at its basis, a myocardial infarction means that the myocardium, myocytes, have died. They've infarcted, right? And so they die because they didn't get enough blood supply for one reason or another. But there's lots of reasons besides a plaque rupture acute coronary syndrome that your myocytes could die. So this is just showing that there are other possibilities. So heart failure we talked about. Tachycardia or bradycardia because you're not getting enough cardiac output and enough flow down the coronaries. A cardiac procedure. If I go in and blow up a balloon in your artery to open up a blockage, well, for those seconds that I blow up the balloon, I'm not getting any blood flow down the distal artery. So you see that there's a lot of different reasons why you might kill the myocytes. So this has been the source of a lot of debate, and you can imagine cardiologists will publish on anything. And so this is the accepted universal definition for a myocardial infarction. So you have to have multiple things. Troponin alone is not enough because we're trying to get at understanding mechanism here. So you have to have rise and or fall of a cardiac biomarker with at least one value greater than the 99th percentile. So that means that you have to be above that limit in your lab, whatever that limit is. I think ours here is 0.03, something like that. So it has to rise and fall. If it's just stable like this, that doesn't indicate that you had an acute event which killed the myocytes. It has to rise and fall, but you also have to have either symptoms, chest pain, shortness of breath, some new ST or T wave changes or a new left bundle on your EKG. So you have to have EKG, one of these, development of Q waves, or you could see on imaging. So maybe you got an echo and you have a new regional wall motion abnormality, or you got an MRI and you saw a new scar, or if you actually see a thrombus inside the blood vessel. So the point of this is that the cardiac biomarker elevation is not enough. It has to rise and fall. And then you have to have it associated with something else which indicates that this is myocardial ischemia. So that's what we use as our universal definition of an MI. But then you can further break it down. Who's heard of type 1 versus type 2 MI? You guys familiar with that? Ever heard of it before? Good, none of you. Oh, come on. I know the Kavanaughs have. You've rotated with me. We talked about it. Good. Okay. So whenever we say, you'll hear people say type 2 MI quite a bit. What do we mean by type 2 MI? Yeah, so that's another word people will often use. I tend not to exclusively use the word demand because there might be other reasons, right? So there's all these other types here that all are indicating this is not from a plaque rupture. But type 1 is because of you had a lumen of your vessel and all of a sudden, boom, something changed inside the lumen of the vessel. Either you had plaque rupture, a dissection, or a plaque erosion. Basically same thing as plaque rupture. That inside the lumen of the vessel, that caused the MI. That's very important because I'm going to treat vasospasm very differently than I'm going to treat plaque rupture based on the biology of what's going on inside the vessel. So type 2 is where we have something else going on. That's your trauma patient that got 40 units of blood overnight last night and tachycardic to 150 and has a troponin of 1. I'm not interested. Thank you very much, right? Because you know exactly why that person elevated their enzymes. They weren't perfusing, but it was because they had no blood, not because they had a thrombus form inside their artery. So does everybody understand when we say type 1 MI, that's what we're going to spend the rest of this lecture talking about, but it's important that you've thought through the other possible causes of why you might have cardiac biomarker elevation. Yes? Any questions on type 1 versus type 2 MIs? Okay. So when you present to me in the future in the CCU, you're going to give me, when you discuss, this patient came in and they have positive biomarkers, I believe this is consistent with a type 2 NSTEMI because of the 40 units of blood the patient got last night, etc. So you're going to use this in your definitions. So this is what I'm always thinking about, and this is what I want you to think about. Always understanding what's inside the blood vessel. Now, it's a little bit hard to see. So this is hopefully what my arteries look like and yours, although by the time you're in your 30s, you have some fatty streaking. Sorry to tell you about that, okay? But I hope that mine look like this. My HDL is awesome. Okay, this right here, now I have lipid and cholesterol buildup inside the artery. What clinical syndrome might I have when I have this, let's call it a 70% obstruction of the lumen? How might I present here? Exertional angina. Who said that? Someone get some candy. Oh, not at all. Good. Okay. Just throw it to people. Good. Yeah, so this might give me exertional angina, okay? But notice, there's a thick cap on top of this atherosclerotic plaque. That is very different than here, okay? Now this right here, I have that plaque, but now the plaque has started to get disrupted and I have some little platelets there. What syndrome might this give me if I'm having buildup of platelets and breakdown and buildup and breakdown? Yes, that's right. I definitely cannot throw that far, so somebody pass that back to me. All right. I'm going to get candy in boxes from now on. Good. So this might be unstable angina. Now notice, right, you're never fully occluding the lumen, so you're not going to get positive biomarkers because you never fully disrupt that blood supply. And then this might heal over and you might get this 90%, which could give you, crescendo angina, where you start to have angina with less and less exertion. Then we move on to here. Now here I have not only platelets, but I also have thrombus forming, but it doesn't fully occlude the lumen of the vessel. What's this? So it says unstable angina or NSTEMI, right? So it might occlude transiently and then unocclude. So this is probably unstable NSTEMI, which is kind of the hardest one when you think about the vessel. Now I have a thrombus fully occluding. What's this? Yeah, STEMI. Good job. Run to the cath lab. Wow, she flinches every time. I know, I'm really bad at throwing. So this is what I'm always thinking when I approach a patient. What's going on inside the vessel? And it matters. Because this right here, do you think I should give this person, I don't know, an antithrombotic agent? No, there's no thrombus. So there's no point in treating that. But this guy down here who's got a thrombus, if I don't give this person an anticoagulant, antithrombotic agent, then I'm not treating the biology of what's going on. So you always want to know the biology inside the blood vessel. Sometimes you don't know, but you make your best guess. These are some pretty cool pictures. These are actual coronary arteries, and this is actually looking at it to prove I'm not making this up. So here it was a plaque rupture that was occlusive. This was a STEMI. Obviously the patient didn't do too well because we're looking at their pathology specimens. You see that you've had atherosclerotic buildup inside the artery, but then you acutely get this thrombus. This is what's called a necrotic core, where you actually start to break down all of the platelet and thrombus that's inside there. But that was 100% occlusive. Here's a rupture that's non-occlusive. So rupture just means that you've exposed platelet adherence and aggregation factors, that something has changed in this atherosclerotic area that allows the aggregation and activation of platelets and thrombus formation. So here you see that you've formed thrombus, but it happened to not occlude the whole thing. This is probably an NSTEMI, right? And then this is someone who had multiple ruptures, but it kept healing over, and now you've got this significant narrowing of the lumen, and this person probably gets exertional angina. Okay? So that's pretty cool. So now let's talk about how we make the diagnosis. We know what we're thinking about inside of our minds about the lumens of the coronary arteries. What are some things that you use to help make the diagnosis of acute coronary syndrome? Yes, go ahead.
Risk factors.
Good. And what are some of the traditional risk factors?
Diabetes, hypertension, smoking.
Absolutely. Age is the most predictive one probably too. But yeah, in Kentucky, everybody starts smoking at age 5, right? So everyone gets a check on the TIMI risk score for at least 3 coronary risk factors. So risk factors are important. If this is a 22-year-old pregnant woman with chest pain and EKG changes versus a 75-year-old guy with a 300-pack year smoking history, I have a different differential diagnosis for those. So good, risk factors, that's knowing the patient. What else? Good. So you want to actually check cardiac enzymes. Absolutely. There you go. What else? Good. What about your exam?
Well, the history and acute onset CHF.
Okay, so we'll differentiate those two. So the history is going to tell you what's the classic story for ischemic chest pain. What does it sound like?
Chest pain, diaphoresis.
Levine sign, right? Clutching at their chest, feels like an elephant sitting on top of their chest. Now, it turns out, how good are those things for actually predicting it? Not so great, but we still use the determination of typical versus atypical chest pain symptoms. So absolutely, we want to use those. One little caveat, what does sharp chest pain mean? What do you think of when you think of sharp chest pain? Like we think of a stabbing, right? That's not always true. So I trained in Baltimore, and sharp just was a measure of intensity. It took me 5 years to realize when people said, yeah, it's a real sharp pain, they meant intense. And since being in Louisville, I have found that similarly, sometimes people here will use the word sharp to mean intense. So don't suggest that to patients, because you're trying to be like, oh, it's pericarditis, or it's a PE, because it's a sharp chest pain. I don't use that word. I'll ask them, is it a stabbing feeling or a pressure and heaviness feeling? Because if I give the word sharp to them, they might say yes, and all they mean is intensity. Okay, good. So clinical story, risk factors we talked about here. Okay. And then what else? We talked about biomarkers. Oh, look at this, going down the list. What else? What other diagnostic testing do you do for a patient with suspected acute coronary syndrome? Good, EKG, don't forget. And you have to do them repeatedly. I'm going to show you why in a second. And then everyone also should probably get, in a non-urgent fashion, an echo. And we want to look and see if there's any new regional wall motion abnormalities. So everyone gets ordered for an echo, but you don't have to get it acutely. Okay, good. So I'm going to spend this next part looking over EKGs. We're going to predominantly focus on ST elevations because that's the thing you need to be able to recognize acutely. But I'm just going to tell you in advance that when I switch to talking about treatment, I'm mostly going to be talking about non-ST elevation MI because the treatment for an ST elevation MI, as far as you're concerned, is what? Yeah, call somebody, right? Get them to the cath lab. So I'm not going to waste time teaching you about other stuff that I know when I just want you to call the cath lab or call me for a STEMI. Okay, so, but EKG-wise, we're going to focus on STEMI because that's the thing that people have a hard time with. So, first and foremost, you have to know that not all ST elevations are ischemia. Just like we talked about supply and demand in the coronaries, you have to keep differential diagnosis here. So this first I want to show you is considered a normal variant of an ECG. You might see this. Now look, we use which segment here as our reference point for ST elevation? You're supposed to use the TP, but you can use the PR for the most part, right? So you're looking at the PR as your reference, and then you look to see where is that J point and where is your ST segment. Now this person has 1, 2, 3 millimeters of ST elevation, call the cath lab, right? And look, they've got it in contiguous leads. So why is this a normal variant? Well, this happens to be a very common pattern in young men. And what you can see that are the differentiating features here is that this is a concave segment, right? That smiley face up that you've probably heard about. So the segment is concave up. There's usually a big S wave, and then you have this big ST elevation. And this would be like your 30-year-old kind of buff young man who has this EKG pattern. So if you see this and they're having no chest pain, please don't start them on heparin, right? Don't call the cath lab. So this is important to recognize this as a common variant. Now that's different than what we call early repolarization. People will often use those interchangeably. This is also, again, not ischemic ST elevations, but there are ST elevations. Here it's mostly in V4. The one I just showed you is usually V2 and V3. And you have this little notching often at the J point right here. And this is just early repolarization. It's not technically normal, but it's also not pathologic. This is just that the way the vectors are in the heart when the heart is repolarizing give us this shape. So those are important to recognize as non-ischemic. These aren't concerning findings, early repol or normal variants. Okay, now we're going to go through, this is lead V1, V2, V3, and lead 2 are the ones that you have. This is a really great article in New England Journal if you want to go back and look. This is one patient, this is one patient, etc. So we're going to go through and say all of these have ST elevations on them, all of them, but not all of them are acute myocardial infarctions. So does anybody know what this first one represents? See, look, I have ST elevation there, about 2 millimeters. But what pattern is this in? What else do you notice? What's the company it keeps? What's that? So there are technically Q waves, yes, in V2 and V3. And what else do you notice here? What about the voltage? Giant volts, right? 1, 2, 3, 4, 5, 6, 7 big boxes, 35 millimeters. So what is this representing? Yeah, LVH? Yeah, good job. So this is left ventricular hypertrophy. You get some slight widening of the QRS and you get some ST elevation. So this is not of great concern. Okay, next one. Again, what's the company that it keeps? Someone volunteer and just talk me through it. So I have ST elevations, right? Woo! 5 millimeters! What's my QRS look like? Real wide. Okay, once you have a wide QRS, what's the next question you're asking? Good. Which kind of a bundle is this? Yeah, because this is greater than 120 milliseconds. You don't have the full EKG. You have lead 2, which is upright, and you have V1, which is down. So what kind of a bundle is this? Yeah, left bundle branch left. Did you say that, Brittany? Oh, behind you, sorry. There you go. Whoever got that. So this is a left bundle branch block. Now, the ST segments are often in the opposite direction of the QRS. This is why you can't adequately interpret ST elevations in the setting of a left bundle, because you always have ST deviation with a left bundle. This is just a stable, normal left bundle branch block. Okay, good. Next, ST elevations. Which leads are the ST elevations in? Okay, is there ST elevation here? Technically, yes. Look at, that's my PR and that's where my J point is. So there's about 1.5 millimeters there. Is there ST elevation here? Yes. Is there ST elevation here? Yes. Is there ST elevation here? Yes. So if I say diffuse ST elevation, you say pericarditis. That's right. No one gets that one because I led you to it. Okay? Next. Company that it keeps. Look at the T waves. Hyperkalemia. Excellent. Oh, I always miss that one. Oh, whatever. Okay, you wouldn't want to sit on that, right? And see this pattern, this kind of coved dome shape? This is a more classic ST elevation for hyperkalemia than it is for acute ischemia. This is hyperkalemia. Okay? Next. Chest pain. Yeah, that's right. Is anyone else nervous about this besides Nelson? Yeah! Look at this. This is 11 millimeters of ST elevation in the anterior leads. And there's a Q wave there. So that's been going on for a while. This is an anteroseptal MI. Please call me. Please call me. Good. These are massive. And see, you have this domed, frowny face shape to the ST segment. This is classic. Okay. This one's a little bit harder. What's going on in this one? So first, are there ST elevations? Exactly. And there's only ST elevations here, right? V1 through V3. Okay? What's going on with your QRS? Yeah, and in what pattern is it wide? So you're positive in lead V2, well, V1. So if you're upright in V1 with a wide QRS, that is it's only 50-50 chance. What kind of a bundle is this? This is a right bundle branch block. So the point here is that this is a person who's having an anteroseptal MI, but they also have a right bundle. But as opposed to the left bundle, where I can't interpret the ST segments, I can definitely interpret my ST segments with the right bundle. Yeah?
Now, a question with left bundle branch block, if that's a new left bundle branch block, that's the same thing, or that be considered ST elevation?
I'm so glad you brought that up. I'm going to take a side note and tell you exactly what I think about that. So, the reason why chest pain plus new left bundle triggers everyone to think this is an acute MI is exactly what you said, because we have difficulty interpreting the ST segments in the setting of a left bundle. But let's take it a step further. What is the blood supply to the left bundle? Which artery feeds it? Does anybody know? It's multiple. So the left bundle in and of itself does not say, oh my gosh, you hit the LAD, because the LAD is what supplies the left bundle. The reason for the concern is because you can't interpret the EKG. Now, let's think about a right bundle here. So a right bundle branch block, what's the blood supply to the right bundle? The first septal perforator off of the LAD. So I am actually more diagnostically certain when I see a new right bundle with chest pain and ST elevation like this patient has, I think I've hit my proximal LAD. I'm still concerned if I have a new left bundle and chest pain, but I have no idea what artery and whether I'm dealing with a STEMI or an N-STEMI or what. Does that make sense? So we teach you, be concerned about a new left bundle because you can't interpret the EKG. What we should also teach you is be very concerned about a new right bundle because I can interpret that EKG and I can tell you that they're having a proximal LAD infarct. So this is a very concerning EKG for being very proximal in the LAD. All right? And then last. So, is there ST elevation here? Yeah, but it's kind of wonky, right? It's this weird kind of shape. Does anyone recognize what that pattern is? Brugada, you got it. So this is more about channels and repolarization than it is about ischemia. Okay? So again, this is a great reference in this article if you want to go back through and quiz yourself. Not all ST elevations are ischemia. But sometimes they are. And when they are, I want you to think about vectors, right? EKG is like a 150-year-old technology, and I still use it every day that I'm working. That's pretty remarkable. This is all about the sum of vectors, okay? And so here's what you need to remember about ST elevations. The ST segment points towards the area of injury. So that's how we can use our EKG to localize it. So here, this is a person who's having an anterolateral MI. So here's the area where they had the blocked artery. The ST segment points towards that. So when I'm in lead 1, which is going to measure this area, the lead 1's going to be up. But if I look down here at lead AVF, remember my vector's pointing like this. So my ST segment's actually now pointing away from lead AVF. So my ST segment is down. And let that sink in for a second. Does that make sense? So the ST segment points towards the area of injury, but my leads are in different spots on my chest and they're looking at different places. So depending upon where my vector is going, every lead is reflecting the same vector. It just depends upon what angle you're looking at it from, right? This is like basic geometry going back to that. So in this lead, the ST segment is pointing towards it. Therefore, it's positive. In this lead AVF, my ST segment points away from it. Therefore, the ST segment is negative. So when you look on the chest, you have to remember what the leads are pointing to. V1, V2, V3, V4, V5, that's pretty easy, right? Because you know where those are in the chest, and those are just measuring literally at that spot. The limb leads are a little bit harder, and you might have to draw yourself out this diagram, but in general, you remember that 1 and AVL are lateral, 2, 3, and AVF are inferior, and AVR is way the heck up here. AVR doesn't tend to measure very much, but if AVR is up, if the ST segment is up in AVR, and everything else is down, that's very concerning. Because that tells me I have global injury going on because my injury pattern is pointing towards AVR away from all of this stuff here. So that it signifies global ischemia. So that's when AVR is helpful. So this is important to have in your mind to know what you're measuring with each lead and what territories they represent. Okay, now we're going to have some fun. These are from real patients. Diagnosis, please. So first, chest pain. What do you see?
Clear ST elevation.
Good. Thank you. Okay, so where are they, Nelson?
2 through 4.
2, 3, 4, absolutely. V5, I'm going to also say there's a little bit there, and then by 6, we'll probably calm down. Okay, good. So what territory is that considered? Anterior, and then getting over towards lateral. Whenever I see anterior, I'm also going to look over here laterally, 1 in AVL. Do you see elevations here? Not as pronounced, but there is. There's 1 millimeter and 1 in AVL. So this is an anterolateral MI. Bonus point, which vessel is this? Because we know. What vessel supplies the anterolateral wall of the heart? Okay, you said there's 3 vessels and you've given me the 2 wrong ones. This is the LAD. And it's probably the mid-LAD, which I'll teach you how to think that another time. But this is an LAD infarct. Hello, lights and sirens to the cath lab. Good. Okay. Next. It's going to be a little bit hard to see. Where are the ST elevations? Good. What territory is that? This is inferior ST elevation MI. Now, look at this. 1 and AVL are down. Why? This is what you call reciprocal changes. That's correct. Because these leads are lateral, remember? These leads are inferior, so they're kind of opposite of one another. So if my vector of injury is pointing down, that's away from 1 in AVL. And that's why it's going to be negative in 1 in AVL, positive in 2, 3 AVF. Bonus. Which vessel? Because there's 2 vessels that feed the inferior wall. What are they? Could be the RC or the circ. So how do you know which one this is? Because I do. Besides the cardiology fellowship. So which lead is higher? Which one do you have more ST elevation in? 3. Okay, remember your diagram. Where does 3 point? 3 is like this. Okay? Is that more towards the right or more towards the left? That's towards the patient's right. So when 3 is greater than 2, with a 97% specificity, you can say that this is an RCA infarct. How sweet is that? Now, someone's having an inferior MI. You think it's the RCA. What's your next step? That's correct. Why do you take right-sided? Who said that? Where are you? Okay, good. Why are you taking right-sided EKGs? Good. So the first thing you can do is look here at V1. If V1 is up, you have an RV infarct. If it's not, you got to do the right-sided lead, and you got to do it now because these changes are going to go away. So then you do the right-sided leads. Now, when you do a right-sided lead, what are you doing? What is that? Just take 3, 4, 5, 6 and put them on the other side. Okay, you got to know this in case the EKG tech doesn't. So you're just switching them over to look at the right side. And you're looking for ST elevations in which lead? V4R, because by the time I switch everything over, that's going to be the one that looks at the RV. Do I have ST elevations in V4R? Yes, I do. RV infarct, you're going to have a beast of a time with this, because RV infarcts are nasty. So this was an acutely occluded proximal RCA that infarcted the RV. Isn't that awesome? Okay, good. Diagnosis. Do you have ST elevations? Aha! Where do you have it? Yeah, in the one that nobody ever looks at. So AVR is up. What's happening else? Everything else is down, and woo! Is this a concerning EKG? Sleep on it. Give them a little morphine for the pain. No, this is global ischemia. This is probably left main disease. So this person, I send to the cath lab right now, even though they don't technically have an ST elevation MI. You gotta know this EKG. Because this person is in bad shape. Okay? Good. Are there ST elevations here? It's not a trick question. No, right? You went back to sleep. Your pager went off, you came, you looked at the EKG, you went back to sleep. But this patient's having chest pain. They're a 65-year-old smoker with hypertension who's had a history of MI in the past. They're having chest pain. No EKG changes, okay. But what are you going to order for that person? You're going to order serial EKGs and markers, right? And you're going to order them every 6 hours. And then you're going to know that tomorrow morning when I come in, if you haven't looked at those EKGs, that I'm going to kick you in the teeth. So you're going to get up at the 6-hour mark and you're going to look at the EKG. And when you get the 6-hour EKG, this is what it looks like. Ah! What is that? What are those? What do you see? Okay, there's ST depressions, and what else? Deep symmetric T-wave inversions. When I say that sentence, deep symmetric T-wave inversions in a patient with chest pain, in the anterior leads, does anyone know the name of these kind of T-waves? Or what they signify? Is this concerning to you?
Yes.
What's your differential for this EKG? What's that? Good. So this could be myocardial ischemia, absolutely. What else when you see these kind of T-waves? There's a couple other things you always think about. Intracranial hemorrhage or stroke can also give you these, and then occasionally stress cardiomyopathy. But the fact that this is in a patient with risk factors in chest pain and that it's in these anterior leads, these are called Wellens T-waves. And they signify proximal LAD, impending occlusion. So this person also, if they're having active chest pain, I send this person to the cath lab really urgently. Because this person had 95% proximal LAD. First EKG was normal, that's why you get others. Yes?
Do those two as the previous EKG same?
The ones here? So he has flattening. And then you have maybe some inversion inferiorly, but very non-specific. So this doesn't tell me necessarily anything about the evolution, but when I get this one, I'm like, whoo mama! Okay, good. All right, diagnosis. Do you have ST elevations? You do not. What do you have? Yeah, ST depressions. Chest pain, risk factors, troponin of 2. What's this? This is an NSTEMI. Okay, good. So now we're going to transition and we're going to talk about NSTEMIs. But first we're going to talk about risk scores. So are you guys familiar with risk scores in the setting of acute coronary syndrome? You heard about risk scores? What's a risk score you may have heard of? TIMI risk score, right? Yeah. So I just want a few words on this. Oftentimes, an enterprising intern who wants to impress will talk to me about a patient's TIMI risk score. But the patient is admitted with heart failure. Does a TIMI risk score apply to someone in heart failure? No. So you have to apply these to the right patient. This is only meant for patients who are having acute coronary syndrome. And what's the point of this risk score? It's not just for good roundsmanship. It's because you're trying to understand, based on registry data that they've collected, thousands and thousands of patients, what is the risk for this person developing an adverse event during their hospital stay, essentially, okay? And it gives you a little bit of help in terms of guiding your management strategy. So the TIMI risk score, it gives you a 14-day risk of death new or recurrent MI, or need for repeat revascularization. And this is the one you may have memorized. It has cardiac risk factors, ST deviation, aspirin use in the last 7 days, positive cardiac biomarkers, typical chest pain, etc., right? You've heard those things for TIMI risk score. You can go online and you can calculate a TIMI risk score. So that's great. But what I like better is, and also note that they have slightly different risk scores for NSTEMI versus for STEMI. So you need to apply the correct one. And so when you present me a patient who's had an NSTEMI, the next morning on rounds you can say, I calculated their TIMI risk score, and it gives them a 14% risk of 14-day mortality, MI, etc. But what's even better is the GRACE risk score. So this is also based on registry data. I like GRACE for many reasons. Number one, it gives you a lot of prognostic information, not just 14 days. It gives me in-hospital 6-month, 1-year, and 3-year risk of bad things happening to this patient. And what it includes are all the clinical factors that TIMI doesn't, right? TIMI doesn't say anything about how sick are they when they present. Because you can have someone who presents with an NSTEMI troponin of 2, feels fine, no heart failure, or you can have the person who's in cardiogenic shock, right? And the TIMI doesn't really differentiate between those two. GRACE includes things like heart rate, blood pressure, creatinine, because we know that if your creatinine's off, everything is worse. So I actually prefer the GRACE risk score. It's not as intuitive to remember, but again, you can look it up online, you can get the app on your phone, and then it gives you a sense of how sick is, or how bad are things likely to go for this patient, and it helps us to differentiate about how aggressive we want to be. So the main point here is apply it to the correct patient, and you should get in the habit that when you admit a patient with an NSTEMI that you're calculating one of these risk scores for the patient. Okay. What's the treatment for STEMI, just to remind us? All right, call someone, right? Go to the cath lab, okay? That's all I'm going to say about STEMI for right now. If you want to learn more, come to a cardiology fellowship with me. But I want to focus on the NSTEMI or unstable angina treatment because you're the front lines of that, right? When you're in the CCU, you're going to have to make these management decisions overnight. And so I want to take the next 20 minutes and we're going to try to go through it. Again, first thing is think about the mechanism and think about the biology. So you have to determine whether you think this person has a new plaque rupture thrombotic event or whether they just have stable angina and treat them appropriately. So who's heard this before? Mona. Did you learn that in med school? Strike it from the record! I never want to hear you say that again. What does Mona stand for? Which of these have been evidence-based treatments that improve mortality in the setting of MI? Only aspirin. Okay? So I actually don't like this because you're not treating the problem. You're not treating the biology. Morphine is just so that they stop yelling at you. But I don't want to actually mask this pain because if the person's having ongoing pain and they're having an NSTEMI, I might actually take them to the lab tonight. So don't snow the patient with morphine so I can't tell that they're having chest pain. Oxygen. Well, if you're hypoxic, yes, please give them oxygen. Don't run to the ER and be like, Dr. Brown said no oxygen, and then they're desatting to 82%, okay? If they're hypoxic, please give them oxygen. But there's actually some very interesting data that shows that giving oxygen is probably harmful. Because if you have high levels of oxygen, what's the damage from an MI? What's the biology of how the heart gets damaged? What kind of species are the things that damage it? Reactive oxygen species and free radicals, right? So it's actually a reperfusion injury. So too much oxygen in that setting is bad. So don't give them oxygen if they're not hypoxic. Nitroglycerin, again, that might decrease, it's going to increase your coronary diameter, right? So that might help with the pain, but it doesn't have mortality benefit. I'm okay with nitro in the right setting, but you have to be judicious with it. Aspirin, however, totally golden. Give it to everybody, okay? So instead of remembering that, I want you to remember the ABCs of treatment. Who can name for me an evidence-based treatment for acute coronary syndrome that starts with an A? Aspirin! Oh man, I put them all up. Okay, good. What else? That's not an A. We're going to get there in a second. What'd you say? Another antiplatelet. Good. So aspirin plus a second antiplatelet. What's another A? We're going to get to the ACE in a second. That's a little star on the side. Anticoagulant or antithrombotic. So those are your A's. Okay? I put anti-anginal here. That's the nitro. It's okay, but it doesn't save lives. And then the ACE inhibitor we'll get to in a second. What's the B? Beta blocker. Good. And what's the C? Cholesterol, statin. Okay? You're not trying to acutely lower the LDL, right? Oh my gosh, the LDL is 150! This actually has anti-inflammatory effects. So these are the ABCs that you remember. We're going to go through them quickly. Antithrombotic therapy, there's been a lot that have been tested over the course of time. And the only two that I really need you to remember when you're starting treatment is unfractionated heparin and low molecular weight heparin, okay? These both activate antithrombin 3. They inhibit 10A and thrombin levels. If someone has a history of HIT, that's when you need to choose something else. But if they don't have a history of HIT, just go ahead and use unfractionated heparin or low molecular weight heparin. Personal preference, unfractionated heparin. Just start them on a drip with a bolus. This is easier for us to manage. Yes?
I do have a question. Something on as a brother talked about dual antiplatelet therapy. We don't typically do it very often in our program. I was wondering, is the rationale because we're taking them out of the cath lab? I always wonder that. Some of it, I would say, with aspirins and like plasma.
Yep. We're going to get there. I'm going to show you in 1 second. It's a complicated area, but I'm going to try to make it simple for you. Okay. So first thing though, antithrombotics. So everybody gets something, heparin or low molecular heparin. Also, don't switch back and forth. So if the ED starts the patient on Lovenox, don't switch. They have more bleeding if you switch, and more bleeding equals more death in general in any time you're dealing with MI. So leave them on whenever they start, but for the most part, unfractionated heparin. Here's my other caveat. Just because you start them on the protocol doesn't mean you don't have to look at the PTT, because how often are people therapeutic? Right? So don't tell me the next morning, patient is still having chest pain, but the PTT is not therapeutic because we haven't been aggressive enough with it. So you have to look and make sure they're therapeutic, but unfractionated heparin is great. So just choose that for everybody. You should bolus them in the setting of acute coronary syndrome and then start the infusion. This is what the protocol says, but you need to know about what you're actually doing. And then low molecular weight heparin is there. I'm not going to talk about the others as I mentioned because it's complicated and only if someone has a history of HIT and then get someone to help you. So this is based on the 2014 updated guidelines. If you have a diagnosis of NSTEMI that's definite or likely, whether you're going to go for invasive strategy, meaning cath lab, or conservative strategy, meaning medicines alone, you're going to use an antithrombotic. Lovenox, unfractionated heparin are just fine. Okay, next, aspirin. This is really old data, 1988, but it's kind of awesome to see that this is where we started. So here's if you treat MIs with placebo, bad. You have 70% survival being event-free. That includes death, MI, and stroke. Aspirin is good. Heparin is good, but look if you combine them. Look at the synergistic effect. We're talking about from placebo to treatment, an absolute risk reduction of like 20%. Absolute risk reduction. When I'm going to tell you about the antiplatelets, we're talking about absolute risk reductions of 1%. So this combination, aspirin and heparin alone, super powerful. Don't forget to put your patients on it. What does aspirin do? Cyclooxygenase inhibitor, decrease levels of thromboxane. Thromboxane is what activates platelets. So if you block thromboxane, then you're going to decrease platelet activation. These are a summary of all studies from the 80s. Isn't that remarkable? Like in my lifetime, we didn't know for sure that aspirin was good for MI. And again, absolute risk reductions of somewhere between 6 to 10% in all these studies of NSTEMI, or unstable angina. How much aspirin do you give? 325 to begin with, and then 81 a day is just fine. That's all you need to remember. Everybody should get that. Okay. To your question about dual antiplatelet. So the first antiplatelet is always, always, always aspirin. Aspirin allergy we can deal with. Dual antiplatelet therapy is a little more complicated. So for the most part, our other antiplatelet agents we're going to talk about act here through the P2Y12 system. P2Y12 interacts with the ADP receptor, right? And so if you block this, then you're going to also block platelet activation. So these are clopidogrel and prasugrel are P2Y12 inhibitors. Ticagrelor and nalcangrelor are two others. I'm going to talk you through them in very short order. Ticlopidine we don't use anymore. Clopidogrel, otherwise known as Plavix, prasugrel. These are thienopyridines. So, are they reversible or irreversible? Irreversible. They bind to the platelet for the life of the platelet. What's the life of a platelet? 5 to 7 days. So once you put this on board, those platelets are inhibited for a week. But they're actually at the non-active site. So they're not in the active site of the P2Y12 itself. That's in opposition to ticagrelor and nalcangrelor, which was just approved. These are reversible. So you stop them and they actually start to go away. So it's reversible inhibition, but they bind at the active site. Okay, so these are the different types of P2Y12 inhibitors that we have available. Now this is a very messy field because we started with clopidogrel, they did the studies, They showed that there was benefit to clopidogrel when you added it on to aspirin and heparin. So then all of the other studies have had to go head-to-head against clopidogrel. So we've not had any without that on board. And there's different caveats to them, so I'm going to try to make it simple for you. So clopidogrel potency, it's less potent than prasugrel or ticagrelor. This is because it's highly dependent upon your CYP metabolism, and I'll show you that in a second. It takes longer to inhibit the platelets as well. If you give ticagrelor, this is actually inaccurate. If I give you a bolus of ticagrelor, your platelets are inhibited usually within 30 minutes. So we love this when someone's real hot and you know they've got a thrombus inside their blood vessel. This is actually an excellent drug because it really quickly inhibits the platelets. Clopidogrel takes some time, prasugrel takes less time. Both clopidogrel and prasugrel are once a day. Ticagrelor is twice a day, and then cost obviously is a big difference because clopidogrel is generic and the others are not. This ends up being a big issue in what I choose to send most of our university patients home with. There's a lot of variability in platelet responsiveness. So I took platelets from all of you, and then we put thromboxane in and see if they clump up together. Then I give you clopidogrel and do the same experiment and see what happens. So this is showing that some people have huge inhibition of their platelets and some people have none at all. So there's a big distribution about how your platelets are inhibited by clopidogrel. You may have heard or you may not have, depending upon things like Verify Now and different assays where we could check and see your clopidogrel responsiveness and whether you had the genetic polymorphism that made you rapidly metabolize it. It turns out that none of that impacts clinical outcomes, so you won't see us doing any of that anymore. But there is such a thing as clopidogrel resistance in the population, and you don't really know who's going to have that or not. The issue with clopidogrel is that it gets heavily metabolized. So 85% of it gets excreted through your gut. The rest of it has to go through the liver, where it's heavily dependent upon your CYP system to get metabolized into finally the active drug. And there are a lot of polymorphisms in these genes in the population that make the variability. Prasugrel is different. It still has to have some degree of metabolism, but less. So there's much less prasugrel resistance in the general population, which is part of what makes it attractive. But you have to be cautious. So these are my little cautions about your various P2Y12 inhibitors. So prasugrel. The problem with prasugrel is it's contraindicated if you've had anything inside your head ever, besides the brain. Okay. So stroke, TIA, or intracranial hemorrhage, there's a higher rate of fatal intracranial hemorrhage with prasugrel. So you must take that history before you give them prasugrel. And if you're not certain, then just don't give it. It doesn't really work in little old people, so don't give it to little old people. And it has a higher bleeding risk, so this is not used for medical management only. So say you have a person that we're not going to send into the cath lab, we're just going to medically manage their NSTEMI, we don't use prasugrel for those people. So it's actually not recommended that you start this before going to the cath lab. So you guys don't ever need to worry about starting prasugrel. That's easy for you, but you should know about it. However, it's particularly effective in diabetics, really effective. So I love prasugrel in my diabetic patients who have been stented. Ticagrelor is a great drug. It's contraindicated if you've had any intracranial hemorrhage. Stroke, TIA, that's fine. But if you have intracranial hemorrhage, then you can't have any ticagrelor. It also causes a fair amount of dyspnea, so some people end up discontinuing it. So if people have bad COPD, sometimes I won't use ticagrelor. And it is okay for medical management. Okay, so how do I put all of this together? Well, here's the doses that I'm going to use. This is really the only one that you need to remember. Just remember clopidogrel. You're going to be pretty safe if you load all of your NSTEMI patients with clopidogrel up front. 600 if they've never seen it before, 300 if they have, 75 daily. Prasugrel, I'll decide that only if they're going to go to the cath lab. And ticagrelor is also a great drug, but you don't need to remember it necessarily. I usually use that for the hot STEMI patients. So in general, you're going to be fine if you use clopidogrel. And now, there's a lot of variability in how this gets practiced. So you'll have some attendings come on and say, don't ever give them a P2Y12 inhibitor because I'll just decide that tomorrow when we're in the cath lab and we can give it to them on the table. That's fine, but these are also indicated for medical management of NSTEMI. So I usually load all of my patients with clopidogrel is usually my practice pattern. If you have some concerns, people will always say things like, oh, but diabetics have higher risk of triple vessel disease, they're going to need to go for cabbage. I don't care. They can wait 5 days to go for their cabbage. That's fine. They don't have increased mortality if they get that before cabbage, just more bleeding. That's okay. We can deal with it. So here are what the 2014 guidelines say. If you're going to the cath lab, you get aspirin plus an inhibitor, clopidogrel or ticagrelor, the first. Prasugrel can also be given at the time of the cath lab. If you're doing medical management, again, aspirin, clopidogrel, or ticagrelor. If you're doing an invasive strategy, you can use prasugrel after you've stented them. So all you need to remember is load them with clopidogrel. That's pretty easy. When you're on service with me, I will not fault you for loading anybody with clopidogrel, and I will want you to for the most part. If there's some question, some other reason why we're concerned about it, then we'll have a discussion. But I want to treat these patients. Yes, question.
Are there any contraindications for clopidogrel?
None of the black box warnings that I showed you for prasugrel or ticagrelor. So if someone is, freshly bled into their head, then we're not going to give them clopidogrel. But there aren't the same concerns that you have with the others. Okay, anti-anginal, quickly, nitroglycerin, no mortality benefit. Remember that this causes vasodilation, and it also may decrease your afterload a little bit, but what it's really going to do is decrease your preload, right? So, do not use nitro in someone who's having an RV infarct. They're preload dependent. They need all that fluid to get through their hypokinetic RV. This is sometimes how you diagnose it, right? Oh, chest pain. Here's a little nitroglycerin. Their pressure is 70/40, right? So don't give these to people that you think are having an RV infarct or who are hypotensive at baseline. If you want to give a little and you're not sure, okay, sublingual nitro is a 400 microgram bolus. An IV drip, I can start you at 5 mics a minute. So an IV drip can be much gentler if you're worried about blood pressure, but you want to give them some nitro to get rid of their chest pain. ACE inhibitor quickly, this has a lot of pluripotent effects, not just decreasing blood pressure, decreases inflammation, affects endothelial function, and long-term remodeling. This is class 1 for anyone who has an MI with LV dysfunction, less than 35%. But if you have normal LV, it's a class 2 indication. I try to get everybody on an ACE, but you don't need to do it right away. We can do it tomorrow. We can get an echo, see what their LVEF is. Beta blockers, these have been studied a lot. Again, they have many pluripotent effects. Class 1 indication, choose metoprolol is usually the one that's going to be best because it's going to not affect the blood pressure. If you have a lot of blood pressure, you can use carvedilol because it will affect the blood pressure. But metop, relatively short acting, that's a good one when you're just trying to target the heart rate in the setting of the acute MI. Obviously, don't give it to people who are bradycardic, hypotensive, or have any AV block because you're just going to make that worse. And then lastly, the cholesterol, the C or the statin. There have been a lot of studies that looked at statins in the setting of acute MI. This you do want to get on board right away. Look at this effect size here. So this is a statin. These are the controls. This is major adverse events. You have an absolute risk reduction of somewhere around 8%. That's pretty darn good. This is in addition to everything else I've told you about. So everybody gets rosuvastatin or atorvastatin at the door. If your liver enzymes are real high because you're in shock, then don't give them. But even if your AST, ALT are 100, that's fine. So the moral of the story is please do not undertreat these patients. Everybody hums back and forth. I don't want to start the heparin. I'm nervous about the clopidogrel. Yes, there are adverse events that have happened, and some of you have been on service with me when those things happen. But in general, we don't want to undertreat these patients. So make sure that you are appropriately monitoring them. If you order an EKG every 6 hours, you must look at it. So you should just have that in your head, and you the next morning will show me that you've looked at the EKGs to look for developing changes, and everybody gets an echo. Your goal hemodynamics, you want to get their blood pressure into that normal range if you can. Don't do this to 80-year-old people, right? Don't get them down to 120/80. But 60-year-olds, that's totally fine. Heart rate of 60. To accomplish this, I use the following. Captopril, which is a short-acting ACE inhibitor. A beta blocker, usually metoprolol, plus or minus a nitro drip in the CCU. I do not use hydralazine unless I have to. The reason is hydralazine causes reflex tachycardia, so I will just worsen my ability to control my heart rate. And then I don't use nifedipine at all because this actually has worse mortality in the setting of acute MI, so don't give them nifedipine. Amlodipine's okay if you have to, but I really try to use beta blockers and ACE inhibitors as I can. And then remember your ABCs. Aspirin, 325, then 81 daily. Antiplatelet, clopidogrel is going to be just fine for most people. An antithrombotic agent, usually choose heparin drip. An anti-anginal, if you need it, a beta blocker, and cholesterol.